today we will be discussing about empathy. So one thing is a word that we very commonly hear, and but also I think we are struggling to get it to practice in full. So what is empathy? It's you feel your patient, but it's very easily said than done, and it's the ability to imagine, because sometimes you have to feel your patient in scenarios which you have not undergone. So you should be able to imagine the situation and understand the thoughts, perspectives, feelings, and emotions of another person or your patient. So some also says putting oneself in patient's shoes. So you get into the shoe of the patient and see, how do I feel in this context? And it also highlights the importance of understanding the other aspects of the patient, not merely the illness, because that is what we are quite used to. And also you have to differentiate it from sympathy, which is the mere feeling of pity. You feel pity for the patient, that's all. But so this is different from that. So I thought I will take 3 examples and discuss so that this empathy thing will get clear. So how do we practice? How do we apply this in clinical practice as healthcare workers? Now we work together in managing patients as a team, and we come across similar scenarios. So let me take an example of a 40-year-old woman treated for pneumonia in ICU, and usually is brought to the ward after stabilizing the patient. And a common scenario we come across is, after about 2 days, the patient wants to go home. So everyone gets agitated. We have managed, we have monitored, all early warning scores were managed, and all difficulties were taken. Now the patient's concern is to go home. That's what they want. So first day they ask from the doctor in the rounds. From second day they trouble the nurses and the sister, let me go home. And after a while everyone gets agitated. So naturally what do? We try to explain the gravity of the illness. We will say you have pneumonia and you need antibiotics. If you are not treated properly, this will worsen. So patient is not satisfied. Why is that? Because we are answering a question in our mind, but not in patient's mind. So what happens, my experience at Anuradhapura, I think I saw the group from Anuradhapura has also joined. If there are nurses from medical wards, Ward 62, they will remember there were several patients like this. So in the initial days at practicing at Anuradhapura, I also used to give this explanation about pneumonia, the severity, everything. Not much of a good outcome. But to later realize, one of the problems in this area is that when someone is admitted, and if they are farmer, having paddy fields, and if they are in a area of elephant and human conflict zone, they are in trouble because their husbands will go to the paddy field to protect it from elephants at night. And there will be a young child at home who is alone, a teenager. And the mother's worry is not about pneumonia, but about the child, right? So once we realized, what we did was, when this request comes, we just ask from which area are you. So if they say Padaviya and Sripura or Kabatigolla, we know there is an elephant. Then we ask, is you're from a farming family? Does your husband go? Yes. Then we ask, do you have a young child at home? Yes. Now, of course, the patient's concerns are dealt. Now we have come into the same thinking pattern or we have felt the patient. Patient is very comfortable. Even if we give a solution or not, now the patient is comfortable. He knows that the healthcare work team understands the patient. That's the first step. Then, of course, you can even find solutions. Sometimes you will have to offer, they are young, if you're a teenager, to come and stay in the ward. You have to break, sometimes the wards will have rules, no bystanders or something. You have to amend them. Why? Because if you allow that teenager to be at home, there will be more damage than the damage from pneumonia to the patient. Now, that is what empathy is in practice. Right? So this is what we will have to understand. And empathy is affected by the socio-cultural and socio-economic perspectives. So you will have to know your population, where you work, and whom you come across as your patients, what are their socio-economic issues. And sometimes the question or the problem comes through that, not the illness. So after that, I stopped explaining about the illness and need of antibiotics. I would ask why is this question coming from them? I think they also understand they have to be in hospital, but they have a greater worry, right? So empathy cannot be practiced if you do not appreciate the socio-economic realities of the population you practice with. So that's one thing you will have to understand. So that is, now put yourself in the same shoe. If you don't know the socio-economic realities, what will you want if you come out of the ICU? I would want to say, stay another day in the ICU and come because I'm safe. Same with you all, right? That is not, so if we put in ourselves directly as we are, of course we will not feel the patient. So that is why it is important. So, because now the conflict occurs, we are much trained to go with this biomedical model. We find a fault, we fix it, and we think we have done the job, right? And sometimes our model is a little authoritarian. Doctor knows everything. So when we think the patient should stay in the ward for antibiotics, yes, that's it. They are not there to challenge. They challenge them for 1 or 2 days. After that, they get, the relationship gets disrupted. So similarly, a second scenario, again a common scenario we come across in this country. You get a patient with meningoencephalitis, the patient comes confused, we fever, we do at midnight do the lumbar puncture, start empirical antibiotics immediately. The patient was drowsy, confused, all that. And after 3 days time, the patient starts recovering. So in about the 5th day in the round, they says, doctor, can we go home for a day to home and come? We can come back in 1 or 2 days time. Why? Because we do want to conduct some spiritual activities, because they have gone to the astrologer, the horoscope has been shown, and then has said it's a bad time. If you can keep up to 30th of June, you are safe. So in order to do that, you have to do these ritualistic things. And they will say, we have actually started them by now, and that is why we are seeing these good effects, right? And that is the time whole healthcare team gets into, sorry, අපි ඔක්කොම කරලා බෙහෙත් දීලා මෙව්වා ලෙඩා බේරගත්තාම දැන් අපි නෙමෙයි දෙයියෝ වෙන කවුරු හරි තමයි දෙයියෝ. And you see in Facebooks also junior doctors, nurses sharing their views. We save their lives, God gets the credit. Why is this? Why is this problem in our minds? This is because, again, we have failed to realize the socio-cultural and anthropological perspectives in where we practice. Whether they like or not, our patients is being born to this society. And from their childhood, they have seen these practices. They have undergone for their marriage. They have gone to the astrology and look for a good time to marry. So, whether irrespective of whether these are right or wrong, true or false, this is the practice we have. So, when they are challenged with death, won't they go to the astrologer? They will go. And they will come and tell what they hear, because they also have a belief on those. So we should not get agitated. We should be able to put ourselves in their context and see, why is this request coming? So if you understand this, appreciate, of course, they feel that they have been failed. And of course, you don't need to send them home. You will be able to discuss with them and give some acceptable solution. You tell, okay, chant whatever you want and bring it, and the talisman, keep it under the pillow. We will accommodate that. Or if you want to put a thread, you come and put it, right? So acceptance, and it's not that we are agreeing. We are accepting that perspective and we are accommodating to a certain extent, but in a way that will not disturb our management. And if you can do that, if you can get your mind agreeable to this, and you work together with your patient, the patient will be very happy. I have instances where, these have been tolerated and accommodated, and, but didn't send them home or anything. When they are discharged, now they have given the credit to the astrologer for recovery, everything, but inside them they know we have helped them, right? So that is why they would come and say, Doctor, බලන හඳහම් බලන එක නම්බරේ මං ඕන ඩොක්ටර් දීලා යන්න. right? So that is, now we have felt, and they have felt that we have felt, and because of the gratitude they have, they want to help us also. Now, this is the ideal kind of relationships we can build if we are empathetic. But in order to be empathetic, we will have to understand the society's anthropological, social, and cultural perspectives and respect them. We might not agree with them, we might not follow them for ourselves, but we have to appreciate them and accommodate them for the benefit of our patients. Right? And it makes this whole exercise and our practice joyful also. Then the third scenario, so understanding, appreciating the anthropological, cultural, and religious complexity of patients. The third, then what are the benefits? It improves the patient's satisfaction and trust. They are naturally, they will have more trust on you. They will have better compliance because they feel that we feel them. They have reduced anxiety and stress. And for us, it is better and appropriate decision making. It will help. And it will improve our well-being and burnout because we have less anger spells during the wardrobe, right? The third scenario, this is not exactly related to the patient, but of course it is again the patient because the relatives of the patient and the caregivers and the bystanders are all, part of the patient management. One common practice is when we have a patient, several relatives and friends of a patient ask about the same patient from the ward staff. That is the point again where we, throw our, qualities. Because the same patient, wife comes, another brother comes, another friend comes and asks. So we think, now but then put yourself, in this time, of course, I would ask you to put yourself in the shoe. What do you do when one of your nurse colleagues get ill? My experience is about 20 nurses come with the patient if there is a acute illness. Okay? Same with us. In fact, recently, 2 weeks back, I was with one of my friends who have fallen ill. They are about 20 or 25. Okay? So what is this? Is that right? We all know, do you all need to be there for the management? No. But what? This is our socio-cultural context. This is how we show our bond with our friend or relative, right? So we will also inquire about, what's happening with that patient, all that, knowing that, patient information is confidential. So if you know the doctor who is managing, he will give a call in the evening and ask. We are not their relative, we are just only the friend. But what does that show? That show our concern, our bond, our friendship. That is how our culture has trained us to show these relationships. Whether it is right or wrong is another dialogue. But that is what your patients, their relatives and friends do. So if we understand, when there are several inquiries about a patient, if you are empathetic, we will understand its context. So we are not going to answer all these questions or requests, but we will tolerate and we will find ways of slipping it off. We will say, today the wife came, we gave a detailed account. She knows, why don't you give a call and ask, and if there is any other doubt, you come next day. They won't come, right? So this is how you handle. And if you can do this, part of the conflicts in the wards are over. This is one big problem because, you get, when there's a patient, always when the doctor, someone is there, you get phone calls. And sometimes in the other end, you get, may passeni ekkena ahanne doctor. But this is, so if you know the reality, I think you will be able to deal better. So understand the perspective of social and cultural values given by the society. These are values. So we all adhere to these. But when we see a layperson adheres, sometimes we get little annoyed. So how to improve empathy? So first thing, we will have to understand, appreciate, and be sensitive to social, economic, and cultural, anthropological, and religious perspectives of our patients. Then we have to learn to actively listen, right? And then and understand their view, which is important for them. And also to think that they are partners of decision making. And also to be aware, we can't do this times when we are having burnout and fatigue. So if those are kept in mind, I think we can improve in empathy slightly. Thank you.